Good morning, everyone, and welcome to QI Power Hour. It is 9:30, so I'm going to get us going. My name is Tracy Sharon, and I'm the CEO at the Saskatchewan Health Quality Council. For those of you joining us for the first time, QI Power Hour is a free monthly webinar learning series hosted by us at HQC, and we bring together improvers from a variety of sectors with an interest in improving health and to learn about quality improvement related topics. So before we begin, I want to pay my respects to the original peoples of this land, now known as Saskatchewan, including the Dene, Cree, Saulteaux, Dakota, Nakota, and Lakota peoples. I am joining you from HQC's home offices in Saskatoon on Treaty 6 territory in the homeland of the Métis. Also acknowledging that the Health Quality Council, we support the entire province, which also includes traditional lands located within Treaties 2, 4, 5, 8, and 10 as well. And as we all approach the National Day for Truth and Reconciliation coming up at the end of the month, I'd ask all of us as treaty peoples to take on our responsibility to both learn about and acknowledge the truth of our history and our present, as well as take whatever action you can. I know there are many events and opportunities to learn and engage with community and to take action to further reconciliation. And so I'd encourage all of us as that day approaches to think about what we can do to further our learning and our reconciliation. For those of you who may not know as well, if you are interested in our past QI Power Hour sessions, you can find those on our website where you can listen to the audio of this session or any other sessions that you're interested in. And while you're there, you may want to sign up for the QI Power Hour email newsletter, and that will give you notices about upcoming sessions and details on how to register straight to your email inbox. So be sure to sign up for that while you're on our website as well. Over the past several years that we've been hosting QI Power Hour, we've been really excited to see the continued growth of this session and interest in learning about quality improvement across Saskatchewan. So not only in our home province, but also across Canada and around the world. So we want to thank you for spending an hour of your time with us and for your commitment to the ongoing learning and improvement of the systems that you're each a part of. We really like for you to engage with our session and our content today. And so you're all in listening mode right now, but you can share with us using the chat function, and there are some instructions on the screen for how to do that. And I'm assuming many of us after the last couple of years are very familiar with how to do that. So please do engage in the chat. You can put questions, thoughts, comments in there, and we will have time at the end of the session. I'll be monitoring those, and we'll have some time to pose some questions to our presenters at the end as well. So please do engage in the chat. And without further ado, we're very privileged today to have with us Dr. Lisa Broda and Marcy McComber from the Advocate for Children and Youth Office to share with us information about the report Desperately Waiting, the Advocate's Review of Mental Health and Addiction Services for Young People in Saskatchewan. So Dr. Lisa Broda brings nearly 30 years of experience working in senior leadership roles within government, community engagement, and research. She has worked extensively in the fields of children's rights, children exposed to violence and suicide, and intimate partner and domestic violence. In her role as the Saskatchewan Advocate for Children and Youth, Dr. Broda works collaboratively with children and youth, families, ministries, First Nations and Métis governments, and other stakeholders to improve outcomes for young people. She embraces the truth and reconciliation calls to action and the principles of reconciliation in her work and the work of the Advocate's Office. Dr. Broda also sits as the current president of the Canadian Council of Child and Youth Advocates, an association of legislated child advocates across Canada, working to identify national issues and address areas of mutual concern. Welcome, Lisa. Marcy McComber specializes in human rights with a focus on the rights of children. She holds a Master of Human Rights practice and has over 18 years of experience in the field, having previously worked as an investigator with both the Saskatchewan Human Rights Commission and the Advocate's Office. In her current role with the Advocate, Marcy brings a child rights lens to research, legislation, and policy, and supports the Advocate in creating systemic change at the provincial, federal, and international levels. Her recent research has emphasized the right of children and youth to participate in matters that affect them, specifically in the areas of suicide prevention and child and youth mental health and addiction services. And so we're very pleased to have both of you with us today and to share with us some very important information about mental health and addiction services for young people in Saskatchewan. So Lisa and Marcy, I'll turn it over to you. Thank you.
Thank you so much, and for those wonderful introductions, and for having us today. We really appreciate it. We too are coming from, so everyone knows, Treaty 6 territory, and we do recognize and acknowledge the various traditional territories and treaty lands from which we're all joining from this morning. And I just want to say a real big thank you. I don't know how many of you are on, but just to, we always want to say how we appreciate and have such gratitude for all the work that people do for children. While our office is the Saskatchewan Advocate for Children, we know there's a lot of great advocates out there for young people, and we really all do need to work together to have the best outcomes we can for young people. So I just want to acknowledge that as well. So Marcy, I'm going to cue you to change a slide, and if something happens and people can't hear me or something, I'm sure you'll let me know if something starts glitching. So just a little bit about who we are. We're here to talk about desperately waiting, and we'll get into that shortly, but I just want to make sure everyone understands our office. So my office is an independent office of the Legislative Assembly, and what that means is that we act independently of all government and agencies and publicly funded health entities. Our mandate ensures that we're serving children and ensuring that the services they receive from any child serving sector, that they're receiving those services to which they're entitled, and that their rights to these services are upheld. So we take more of we're a nonpartisan, non-biased, we take a non-adversarial approach, although sometimes I have to say a lot of hard things to those who are serving children when things go wrong or when we see systemic issues that come to our attention in whatever way that happens. Our legislative authority comes under the Advocate for Children and Youth Act, and you'll see on the slide there's 4 arms of what we do. And one of the arms is advocacy, where we do individual advocacy. We get about 1,800 calls a year. Anybody can call our office. It's confidential. When you call, if you have concerns about a young person, a child, you can call us, and that we can find out things about that, make sure the child's safe, make sure the child has services, and that's done confidentially and without breaching your confidentiality. We also do investigations, and if you've gone to our website at all or seen any of our work, our Desperately Waiting is a research endeavor rather than an investigation into a child death or something like that. And in those, we'll get notifications to children who've died or have been injured, or maybe we're doing, there's a case in our advocacy stream where we have to investigate that. To make sure that the child has what they need or is safe. We learn about our systemic issues through those 2 arms of our work. So our advocacy, we can see themes coming out through the year about what we're seeing and what we may have to do about it. A lot of our stuff, the work that we do, is internal, in the sense that a lot of people may think, well, why don't they publicize everything that they do? And we do. We have our annual report year over year, and also, we may publicize things from time to time, as you'll see on our website. But we learn about systemic issues and how we might want better outcomes for those issues through those 2 arms, and also sometimes through public education. We have regional advocates that are out across the province. They are advocating with children, but they're also talking with stakeholders or meeting with First Nation communities or agencies, or just all over the province, corner to corner, and we learn through that mechanism as well. But one of the primary work that we do there is just around making sure people know about our office as well. So we want young people especially to know who we are, that they can call our office, and that we can do our best to help them get what they're seeking, what they need, what their needs are. And then the last arm you'll see there is research and advice. So we can, under the authority of the Act, under Section 14, we can make recommendations to government, advise government about some of our findings around the issues that we see, and that is what you'll see in the Desperately Waiting report. So again, if you go to our website, you'll see a lot of public reports and just what our office is all about. Marcy? So the vision we have here is that children are our primary client. So we want to make sure that the rights, well-being, and voices of children are upheld, they're respected, valued, and supported so that young people can live to their full potential. So to do that, we have a sole purpose of we're listening to young people, amplifying their voices and perspectives in the work that government or agencies or any entity does that works with children, just really with a focus to improve their lives. And to do that, we created a youth advisory council this last couple of years. Through COVID, we were able to have young people come and create a council so that we have, this ongoing body of young people that help us and are integral to our work. So, empowering children to provide their voice and have a forum to do that is really key to the future, because we need to support and uphold our young people. They're the next leaders of our communities, and I know many of you can appreciate and know that. The priorities that I set when I was appointed about 3 years ago, we wanted to really, we met and thought, really thought through, what do we want our priorities to be? Well, we're about children. Children are our primary client. So we want to have their voice at the table. We want to ensure that we're upholding their rights, that they have a voice in matters that affect them. And Marcy's going to talk a little bit about rights in a little bit here, but that was one of our primary considerations, and also to help support them in self-advocacy, because what we've learned throughout our time, at least here, that young people often struggle with trying to advocate for themselves. So we've created a self-advocacy workshop, actually, and we go out, we've been out quite a bit actually in the education systems in the schools, presenting that and giving our young people a workbook and showing them how they can self-advocate and what to do in certain situations. So that's one thing we do under this priority. We want to, again, advance children's perspectives in all the work that we do, and have government do the same. And then just create and support opportunities for young people as well to enhance their growth and development. On the priority of reconciliation, I think everybody, like you, we acknowledge our lands and how important reconciliation is. And we've been really working hard to put it into action, because, and part of that is strengthening the relationships and building those relationships with Indigenous communities, with Indigenous leaders, and Métis communities as well. But we really thought, to live it, we'd have to really connect with the elders and have their guidance in our work. So you'll see in our 2021 annual report, because I think we showcased it in 2020 as well, but who our elder committee is. So we have an elder council, and we really rely on their guidance and their cultural knowledge to help inform the work that we're doing as well, particularly around when it comes to Indigenous children and families, because we know that they make up a huge part of the child welfare system. And when they're in that system, they're going to be in other systems. So, that's another key priority for us as well. Prevention is also something else that we set out. We do a lot of research. We use an evidence-informed practice, but we also want to promote and support entities to do that as well. So that, working preventively helps us get under some of the factors that lead young people to face the challenges that they have when it comes to their mental health. So we know that interrupting and getting underneath and working preventively is key. We know working preventively is key in child welfare, and nations that are drawing down their jurisdiction to take over child welfare is key to that, because they work preventively. And I support that. I've been public about that. And that's also part of our reconciliation, we'll call it. And then the last is just around public awareness, which I talked a little bit about. One arm of our work is public education. So of course, that's really important that we're working to create awareness about our office, to engage with young people, families, communities, stakeholders, everyone who works with children, to let them know about our office and what we have to offer young people, and how we hold entities who serve young people to account for those services and best practice and best outcomes we can. And also just to educate the community and children and families about rights and current issues around children. These are all pretty core to our work, because this is how we go about to do the work that we do, and certainly is foundational to the work we did with the Desperately Waiting report. So when it comes to, so now we'll just turn our attention a little bit to the core reasons why we went down the road of looking at the kind of the state of the nation, if you will, on mental health and addiction services for young people. We all are aware, and I'm sure all of you are quite aware of the statistics, and I won't read all these on the slide, you can look, but it paints a strong picture about what's going on for young people. And we know that suicide is the gravest outcome that young people face if they die by suicide, especially when, there's been gaps in access and gaps in services. It's a sad commentary to what's happening for services for children when that happens. When we look at Indigenous children, youth, it's substantively overrepresented when it comes to attempted suicide and suicides. And I reference, and you'll see this in the report too, the work done by FSIN, because they've been keeping very good track about what's happening with their young people. And so just to give you some comparisons, and you may know this, but the suicide rate for First Nation girls 10 to 19 is 29 times higher than their non-Indigenous counterparts. And for boys, it's 6.4 times. So that's just out of sight. And so, we have to do a better job with respect to examining that, looking at that, moving forward. There's been lots of great investments federally and provincially too that are pocketed from my view. And so we'll have to sort that out for the overall picture, but that's, critical. So we know we have to, deal with this issue, and we have some recommendations to that end. Problematic substance abuse and mental health disorders often go hand in hand. And so when we speak of and look at these stats too, we have to remember that the addiction pictures, most of you will all know this, you probably work in the field, those are here, that they're co-occurring, and, that complicates the matters when it comes to services. Our primary data was collected before COVID. When we started looking at all of this, we were kind of doing a sort of an assessment of, what do we have in front of us? What are we trying to understand here? What are we trying to unpack? And how can our office, with the leverage we have, make recommendations? And so that's why we went down this path. How can we do this a little different than what's been done before? Because a lot of what you're going to see isn't new, and Marcy will speak to that. But I guess, pre-COVID, it was a significantly grim picture. And now we have post-COVID, and we're seeing, the effects of that, and that these statistics, we'll have to do something, because young people are suffering post-pandemic, because all of the factors that were affecting them pre-pandemic are now, just exacerbated by the pandemic. So, Marcy? And, again, 1 in 3 youth who've self-harmed, don't know where to go for help. So access becomes key. So we know some things, but yet we're still struggling to figure out how to get services to young people. Less than half the youth experience depressive symptoms, considered suicide. Just under half within the last year reported having seen a therapist, in mental health never having seen one. And significant wait times for ER continue, and mental health counselors, child psychiatrists, we heard a lot about the gaps there, and the need for resources. And we also, and Marcy will talk about this probably in a little bit, but we know that a lot of psychiatrists have told us, and not to mention this is in other literature in the psychiatric forum, that often young people who come and end up at the ER and who end up in their office are experiencing more problems of living than they're experiencing psychiatric disorders. So what we do know substantively is that young people are using these resources that need to be for other, it's become a crisis situation in the ER when it comes to young people showing up there, because there's no middle tier. There's no place for kids to go. Even though, and I say that against the backdrop, because some communities will look different than others, and we recognize that in the report, but we know that there's those significant gaps that land those young people in the ER. So I'll just say before we move on off the slide, one more thing on this is that our report, like what triggered this report, was really looking back into the past. First and foremost, seeing the issue in the current through our office with all the work through our child deaths, our injuries, because the bulk of what we see there is often around attempted suicides and completed suicides of young people, but also the advocacy calls that we get as well. So if you remember earlier, I was saying, how do we identify our systemic issues? Well, it's through those two arms, plus kind of looking back to see, well, what's been happening along the way, and our statistics paint that picture for us. It's all the best we have when you're trying to look at an issue. But I also looked back to see where has government been with this the past 20 years? Because our first point of reference was the mental health and addiction plan, action keyword. But I thought there was something else. I remembered something else from the 90s, and it was the action plan for children. And in there was a lot of discussion and action to be taken around getting young people services then. So that's why when you read that section of the report, if you haven't, I just raised that to you because there's a trajectory there of accountability in my view. That we have all of these documents, the action plan for children. We have, it's a time for a plan for children's mental health, which my predecessor, Deb Parker Lowen, put out in 2004. And then, of course, there's the action plan in 2014. There's been some stuff in between. And then we had our listen report. And then, there's other key things happening that are really great that the government's doing, but we still have to assess what it really means. The Pillars of Life as the Suicide Prevention Plan and the Saskatchewan Strategy for Suicide Prevention Act. So I think, those are good things, but here we are. So that raises the question of, us going, okay, well, we look back and this is something we need to sort of get a current understanding of in terms of what we should be doing. I am just one sec. I'm getting something that might say I'm rebooting. Please no, remind me in 20 minutes. Okay, I'm good. So although the government's made some efforts, I do want to acknowledge that. And we do say that in our report. And hold that slide right there, Marcy. I'll come to it in a sec. I just want to add that there's still a long way to go. And again, it's been slow. It's been pocketed. There's been some things. We've had some struggles. And now we're outside on the other side of a pandemic that's not declared over. And our health system is under significant pressure. And that's deeply troubling to me as the advocate because, and probably all of you, because you're all advocates for children too, that we really need to figure out how we're going to do this in a coordinated and streamlined manner. So what you see here on this slide is that we just a little quick scope in case you haven't been able to delve into our report yet. And I'm not going to say too much about this. We use structured interviews, focus groups, written submissions from children and youth primarily. About a quarter of our data set was young people, parents, caregivers, health, child welfare, education, corrections, community, police, and judges. And that was all, all of that data informed our themed findings and our recommendations. And what will I say is that we talked all the way from the top in executive government, all the way to the community, nonprofits, governments, like we went everywhere. So it took us a little bit of time. It's a very rich data set from a research point of view. And we asked those 3 questions on the margin there on the other right-hand side about what's been working, what are the barriers, and what are some suggestions for improvement. We wanted to keep it kind of, more the language more friendly for young people too. Like, what do you want? What do you think needs to happen? And that really informed what you see in the report in terms of the findings and the outcomes. Mars? And so you heard me speak a little bit earlier about those underlying factors, those socioeconomic factors that drive a lot of what's happening in our society. And these are just a few. And again, these are coming from young people and one quote from Health. And I'm not going to read them all, but certainly they help us understand how it feels. Like, we all know what's in the literature. We all know what the factors are that drive issues, the underlying factors that require that prevention focus. Yes, intervention, but prevention focus as well. Abuse and neglect and community violence, intergenerational trauma, like these are all things. But when you hear it and read it from a young person, when you go to lack of support for mental health and addiction, if you're too afraid to tell your parents, then I feel like that's the biggest barrier between you and getting help. That really helps humanize what we know. And that was really important for us in the report too, is that we really wanted to make sure that the young first people that we spoke to, that their voice is out and humanizing the issue versus just, painting it out, putting it out in more of a sterile or technical way. So that's what this is. And one of the overarching themes that came was that the system is really reactive versus proactive. This is what this tells us. And it's unable to identify these issues. It's unable to prevent and be proactive around these issues. And when it comes to resources, they're also reacting because they have no choice but to react. So you're always dealing with it and behind the 8 ball, if you will, like always behind it, never ahead. And so that, those wait times and gaps services mean that these issues are often left unaddressed. And we know that adverse childhood experiences that young people have, is going to impact them as they transition into young adult life. So again, just to make that point, and I'm sure that there's nothing that you wouldn't understand about that, having worked in this area or been part of working with children. Mars, thank you. So these quotes were told to us by psychiatrists and a pediatrician. There's lots more in the report, but we just highlight these because this speaks kind of the point I made maybe ahead of the game. It's just around the kids arriving, they're not mentally ill, they're not disordered in a way that they will require psychiatric care. We heard that so much. And I think the important part of that is it's just speaking to the piece around that middle tier care, and Marcy's going to talk about that in a little bit, but and because that's that middle tier we're missing, and that came out very clearly as a finding, like how can we go from having a young person who's experiencing a lot of issues and challenges, and they need help, and then they can't get help, or they get help and they go back, or they can't get sustainable help, they go back, and then the next thing that goes on for how long, and then they're in the ER and they're seeing a psychiatrist. And so this is understandably a frustration in the psychiatric forum because they're seeing it too, I guess is the point. And so just recognizing that, but ultimately at the end of the day, we want to make sure that anything that comes out of these recommendations, that young people are getting those services, and that they are getting it because it's their right to get the highest attainable healthcare service that they can get. So we're hopeful that when we work with governments who have accepted all our recommendations, and we're very pleased about that, and we are starting to meet with them to have robust meetings about what this is going to look like. I'm looking forward to doing that with government. Again, I'll just say this last point, and I'm going to turn it over to Marcy, is that we support the changes government's willing to make. We want to do what we can to be at the table and help them with that. And while we have hard things to say a lot of times, and you'll see that in some of our public reports, and I do encourage you to go to our website as well, we will do that respectfully, fairly, and we'll support the best outcomes possible for children and try to remember we're all on the same page. But also, while saying that, our job is to hold the government to account to those services, and certainly we do that and monitor those recommendations. And I'll come back a little bit to that near the end. Marcy, I'm going to mute now.
Hello. So on this slide, so when Lisa was discussing sort of the mandate of our office, we also want to talk about how the work of our office is grounded in the United Nations Convention on the Rights of the Child, or the UNCRC as we'll refer to it throughout this presentation. So for anyone who may be not familiar, the UNCRC is an international human rights treaty that brings together all of the civil, political, economic, social, and cultural rights that children have to ensure that they're protected and supported in all areas of their life. Canada ratified the UNCRC in 1991, and what that means is that as a country, Canada is actually legally obligated to ensure that the children's rights within the convention are respected, protected, and fulfilled. Human rights in general, and therefore children's rights, really are indivisible and interdependent. So what that means is that in order to fully realize one right, the rights of the child in all other areas have to be upheld. And conversely, if one right is violated, it will negatively impact their ability to have their other rights realized. So an example of that could be a child might be in the best school that there is, but their right to education will not be fully realized if they're too hungry to learn, for example. And so how that is important in terms of situating mental health and addictions within a child rights context is that, as Lisa described, in terms of all of those underlying factors, the social determinants of health, adverse childhood experiences, all of those things that negatively impact the mental well-being of a child, all of these rights need to be realized in order for a child to become the best possible version of themselves. And so the rights that you see on this slide here are only some of the more obvious ones within the convention that apply. But specifically Article 3, which is the best interests of the child, what that means is that the interests of children need to be a primary consideration in all matters that affect them. So nearly every government decision impacts children in one way or another, whether directly or indirectly. And so every government decision maker, policy maker needs to have children's interests and rights at the forefront. Article 6 refers to the life survival, or the right to life survival and development to the maximum extent possible. And that is very relevant to mental health and addictions because development is meant to be interpreted as a holistic concept that encompasses the child's physical, mental, spiritual, moral, psychological, and social development. And so this really does align with conceptualizations of health that are globally agreed upon, such as by the World Health Organization, that states that health is the state of complete physical, mental, and social well-being. And so these are important to the way that we looked at mental health and addictions when we went about our research, because when looking at the right to health through the lens of the optimal development of the child, we see that threats posed to that right by poor mental health or by problematic substance use can exist across a spectrum of symptoms and a spectrum of severity and impact on the individual, and is not limited specifically to diagnosed psychiatric or mental health disorders. So as a result of that concept of health and mental health and well-being, participants for our project were not limited to only discuss issues and concerns and barriers related to services for diagnosed disorders. In fact, they were free to discuss issues and concerns across that whole spectrum. And that's really reflected in the findings and recommendations of a report that really do embrace a child or youth's entire sense of well-being. And so that also means that the child rights framework really does lift the responsibility for supporting positive mental health and freedom from problematic substance use out of the sole realm of the health system. I know that we talked to many mental health and addictions clinicians who said that it can be very frustrating that when people expect them to have a magic wand to be able to, fix the issues that children and youth are coming to them with, when really the onus is on all child-serving entities to ensure that the full range of human rights are realized in order to really ensure that children and youth are developing to the maximum extent possible, as is their right. So you'll see in our recommendations that we'll discuss a little bit later that it really focuses on the need for all systems to work together in the best interests of children. You'll also see Article 2 relating to non-discrimination and Article 24 relating to the right for children and youth everywhere to have the highest attainable standard of health and access to healthcare services. So that I want to talk a little bit about, in that regard, how human rights and children's rights are universal and inalienable. So that really means that they apply equally to all children, no matter where they are, without discrimination, and that they can't be taken away. So how this applies to the highest attainable standard of health means that in order for that right to be realized, children and youth must have both timely access to services, but also services that are provided in a way that are meaningful to them, that recognize both the unique realities of being a child in today's society, but also recognizing their cultural roots and their worldviews, and like I said, in ways that really have meaning to them. And so lastly, Article 12, Child and Youth Voice. So that really is that children and youth have the right to express themselves in any matter that affects them, and to have those in decision-making roles really take their views seriously. So that includes the right to be involved in their individual healthcare decisions, but also in the development of health policy and services. And so this right to participation informed both our methodology of the report as well as a number of our recommendations. So these are these are the findings or the themes that arose from the data we collected. We aren't going to have time today to delve deeply into all of them. We are just going to sort of pull out a few and do a deeper dive into those in a moment. But if you have any questions or want us to elaborate on any of these findings, you can feel free to ask in the chat, and we can cover that in the question period. But generally, our findings, so you'll see Lisa spoke about the reactive versus proactive system already, and we heard a lot of issues around navigating mental health and addiction services that people told us were often unavailable or inaccessible to children and youth. We heard about a lack of access to culturally appropriate services for Indigenous youth. While there are pockets throughout the province that do that very well, not all youth have access to that. We heard Lisa spoke about concerns identified with hospital and acute care services, specifically the capacity of psychiatric inpatient units. And we heard a lot about detox and inpatient treatment for addictions as well. And so generally, overall, the findings really showed that children and youth in our province are facing an under-resourced system that does need to concentrate its efforts on responding to crisis rather than preventing and addressing those underlying factors. And In terms of availability and accessibility, we heard so much from children and youth about the need for connection with their specific service provider and how that's a very important factor in whether those services will be successful. So, when there's not a lot of options between service providers that are available to them, if they can't access them, or if, they have to switch really quickly between youth and adult services, that can really negatively impact the connection and the success of that service. And overall as well, we definitely heard that child serving systems continue to work in silos or place children in boxes, and that, mental health and addictions is often expected to have this magic wand, whereas, systems like child welfare and education and justice may not all be communicating with each other. So you'll see that addressed in our recommendations as well. So in the Desperately Waiting report, we did make 14 recommendations. Again, we aren't going to have time to go through all of them, but please let us know if you have any questions. Specifically when we talk about availability and accessibility, so of course the simplistic solution could have been to recommend, more service providers, more facilities, those types of things. And while that certainly is absolutely needed, we did sort of focus our recommendations around revitalizing and elaborating on some of the recommendations that have been made before, such as through the Mental Health and Addictions Action Plan and other reports that would have the biggest impact on the issues and concerns that were brought forward by stakeholders in our project. We also put forward some new recommendations to hopefully contribute to the existing roadmap, highlighting government's obligations to really focus on the needs, interests, and the rights of children. And one thing that we really do want to stress is that, we know that none of the issues that were really brought to our attention and came out in our findings are not reflective of the hardworking individuals in the system. But when we talk about an under-resourced system, all of the mental health and addictions clinicians that we spoke with, or many of them definitely identified that they're coming up or they're facing their own barriers in getting the services to children and youth that they know that they need. So it's just coming, from that lens. And in general, our recommendations really focused on ensuring that young people are included in the change that needs to happen, as well as shifting focus away from crisis and towards earlier intervention and providing services to youth where they are. And I'll get into those recommendations in a bit more detail shortly. Our recommendations also focus around the need for services to be provided, like I said earlier, in ways that are meaningful to the young person. So, that has to do with, where services are provided, the youth being given a voice in terms of the method or the modality of service provision, as well as access to services that really do respect and take into account and serve the needs of Indigenous children and youth. As well, our recommendations really talk about systems working together. So I am going to pull out just a few of the theme or the recommendations that really do speak to a couple of themes. One of the themes that you saw in one of the previous slides is about sort of navigating the mental health system. And like I said, that really did have to do with availability and accessibility of services. And so how we defined availability in this report was the tangible existence of a service, and also whether there was a sufficient quantity of service providers to provide timely service. And how we defined accessibility was that we looked at whether or not the youth had the ability to actually reach an existing service or meaningfully utilize an existing service. And so these concepts are indivisible at times and definitely related. So in terms of availability, we heard so often that there's just not enough. There's not enough psychiatrists, not enough psychologists, not enough psychiatric nurses, mental health and addictions counselors, school counselors, elders, community supports, youth mentors. That came out really loud and clear. And like I said, that also influences or impacts the youth's ability to access those services, because of course, if they need to travel long distances, or if they have significant wait times in between, that can definitely impact the success of the service as well. And then even if a service is technically available, young people told us that they face barriers in accessing those services. So things like not knowing where to go or which service to call, or cumbersome intake processes, reliance on parents and caregivers who A, may not support them seeking the treatment that they're looking for, or B, just may not have the capacity to assist them in getting to those appointments. They talked about a lack of transportation, especially in rural areas. They talked about hours of operation that really didn't serve their needs because it just made it impossible for them to get to the service. They talked about a lack of outreach, and I'll talk a little bit about that in more detail, as well as a lack of diversity among service providers. So when there's not a significant or a sufficient rather number of service providers, if a youth doesn't connect with one of those, with the person that's available, they often don't have a lot of other choice. So in that context, we did make a recommendation around embedding more services in schools, so specifically mental health counselors and elders within schools, because a large number of our recommendations really do focus on bringing services to the youth to where they are, rather than expecting them to jump through all of these hoops that they've identified in order to find and to get the service. So what they told us is that they really do need these providers to be in the schools where they spend so much of their time. So we know that definitely the ministry is developing curriculum around mental health, and the government has implemented the mental health capacity building initiative within a number of schools and is working on expanding that. And those are all very important in terms of increasing mental health literacy of youth and of the school staff that support them. But young people also told us they actually need people in those environments that they can access in a timely way. And so, yeah, it was really overwhelmingly clear that that was needed. And this is confirmed by research within Canada as well as within other jurisdictions. School counselors are just more familiar with the youth and their environment. They can provide more immediate on-site support for youth to deal with those things that come up day to day and really work on that earlier intervention piece to hopefully address some of those issues before they become more acute and before they lead to crisis. We definitely heard from both school counselors and mental health clinicians in the community that if issues can't be addressed in the school, they do compound. And then if there's not a sufficient number of counselors in the school, they need to triage them just as the community staff do. And then only those with the highest needs get seen at the school, and then only those with the highest needs get referred to the community services, and then only those with the highest needs get seen in a more timely way. And it can just put a lot more pressure on the health system. We talked about expanding outreach in mental health services. So one thing that the youth told us is that it can be very difficult to access services within a system where mental health counseling is really built around in-office visits. They talked to us about how they saw the model that many addictions counselors in different communities use that does have a more outreach-based approach, and how helpful that was in them being more mobile and coming to them. Definitely, even though we do obviously want to see more mental health counselors in schools, we know that many youth who experience mental health challenges or problematic substance use may not be in schools consistently. And so, they definitely identified the need for the counselors to be meeting these youth where they're at, such as in group homes, youth shelters, recreational facilities, and other places like that. They did also talk about the need to expand other methods of connecting with their providers, such as virtually or through texting, or for ongoing services to be provided through sort of untraditional office hours. And so we do know that young people can access walk-in clinics, virtual or text-based services on a one-off basis, either through the rapid access counseling or kids help phone. And while those are very helpful and very necessary, young people told us that they wanted a way to be able to connect with their ongoing service provider in different ways as well. So additionally, expanding the use of virtual or telephone or text-based options could widen the pool of service providers available to youth if they don't feel that they're able to connect with the limited number of options that they have in their community. However, one thing that we do want to emphasize is that there was not consensus among the youth we talked to as to whether they preferred in-person or virtual or phone service. So what that meant is that a variety of options is needed, and that children and youth definitely need to be included in decisions around how their service is going to be provided to them. In terms of another way in which service can be brought to youth, as Lisa mentioned, there's so many times where youth may go to the emergency room in a mental health crisis, but either you know, the inpatient unit is full, or their specific circumstances don't meet the criteria that, you know, require necessarily psychiatric inpatient care. So often we heard from so many youth that would go to the ER and would be sent home, but both the youth and their families really didn't feel that they had the capacity or the resources to address or manage their needs on their own at home, and asked for sort of in-home support services to be available to them to assist with things like you know, respite for parents and families who need to, you know, have their children under 24-hour suicide watch, or transportation to appointments so that these families can continue to, you know, fulfill their other responsibilities, and help with implementing safety plans and other tasks. And so we do know that these services can be accessed through the Child and Family Services system, but definitely that there's difficulties with that as well. And as this is really seen as a health issue, they wanted it to be a health response without being entangled in the child protection system. And Lisa spoke a bit about middle tier care. I think I'm going to speak a little bit more first about expanding and enhancing culturally appropriate services for Indigenous youth, because that really does have a lot to do with access as well. You know, we heard certainly there are, and as all of you will know, there are areas of the province where in services based on Indigenous ways of knowing and approaches are available and work very, very well. But we definitely heard that they are few and far between and that more is needed. So young people told us that they really do need more access to Indigenous mental health and addictions counselors within the current system. As I've talked about already, connection is so important for children and youth. And so certainly our Indigenous young people have experienced unique but collective experiences around the impacts of colonization and discrimination and intergenerational trauma. And they've told us that they oftentimes feel more comfortable and better understood when sharing their experiences with other Indigenous people. So they really did want to see more Indigenous counselors within that system. But they also wanted to see entire resources developed around Indigenous healing approaches and grounded in Indigenous spirituality. So a really positive example is the recent opening of the Woodland Wellness Center in the Orange. And so those are sort of the two ways that young people told us they really needed to be better supported in that regard. And so we know that there is work being done, but hopefully this can be sort of realized in the near future. And so just on the notion of middle tier care, so the government certainly is working towards a stepped care approach to mental health and addiction services, meaning that they do want to see people given the services that they need at the time they need them in the least intrusive way, and then, you know, to move up those steps after that. And so if in-home support is not able to help families keep their children at home, we sort of see a gap in the system still, even then, between that those types of services and inpatient care. So many patients, so many stakeholders rather, called for more inpatient psychiatric beds or longer stays in the inpatient unit because they saw their children and their youth being discharged what they felt to be too early or when they weren't ready. And they said this, or just never admitted at all. And so they said that this sort of created this cycle of going back to the ER multiple times or multiple admissions. And so what people were, and then as Lisa discussed at the beginning of the presentation, we also heard from psychiatrists that the primary needs of these youth are not psychiatric. So these may not be the, you know, inpatient units may not be the right place for them anyways. But yet they don't have those supports available to maintain their progress at home. And so this is sort of envisioned as filling a gap in the continuum of service by offering a supportive rehabilitative environment in which youth can learn to practice healthy coping skills and can maybe access respite if they need from home. And yeah, so I think that that's all I'll say on that point. But if you have any questions, please feel free to put them in the chat. And I will just throw it back to Lisa now.
you so much. I know it's getting close to time. I'm not going to spend a ton of time on these, excuse me, three just around to say that real quick that you'll see in our report that, you know, we've made recommendations about the importance of integrated service delivery and how important it is that we have sectors that serving children are connecting in a meaningful way. And I think when you read about this rec and the spirit of this recommendation, we know that systems do work in silos, and that's been something that's been happening on and off for some time. The last one is around the children's strategy, and I'll just say one or two quick things, and then I'm going to let you ask questions because that's probably important too. But really, this reason I've really been thinking a lot for the last couple of years about a strategy and when to talk to government about we need a children's strategy because of the sectors not connecting, and also because we've had a dwindling and non-existent Saskatchewan child and youth agenda that went to the child and family agenda that just went into kind of just sort of fizzled out. And so to have a strategy and that's comprehensive, it has to be grounded in child rights and be developed with consultation with children. It needs to connect the governments that serve, and it needs to have a longevity and sustainability to it. So I'm pleased they've accepted this recommendation, and this one's going to be one that we're going to, you know, help support them to ensure that it has benchmarks and measurements and things like that. So I think I can see it's 10:20, so I'm going to stop there. I'd love to talk more about this, but you can read and certainly ask questions in the chat with Tracy Fielding, and call our office if you have other questions. Thank you very much for listening to us today. We really appreciate the opportunity.
Excellent. Thank you so much, Lisa and Marcy, for your presentation. And we do have a few questions from folks that are listening, so we'll go to those and see how many we can get to in the time we have left. So I think one, just a question out there about when you say child and youth, you know, how do you define that from when you're thinking about age? Is that, you know, they've suggested, is that under 16, or is there a different age range that you look at?
Well, our mandate's up to 18, and I think if Marcy, correct me if they're receiving services, you know, we do have authority depending who's serving up to 21. We've been advocating for 24 for youth in transition, that the government stays involved to that age, and certainly there's amendments right now with the Child and Family Service Act, so we'll see how that pans out. But Marcy, do you have anything to add?
I guess the only thing I would add is yes. So if they're still so up to 18, if they're receiving services under Section 56 of the Child and Family Services Act, like Lisa said, that's up to 21. Also, if they're still under a youth order with the correction system, then we can still provide. You know, we would still have jurisdiction in that regard.
Excellent. Thanks so much for that clarification. There's another comment in here in the chat, which I am interpreting as a lovely offer of help. And so I guess, you know, there are probably others who are listening who are thinking, who may not work in the system, who may not have any formal role, but might be interested in taking some action based on what they've seen or wanting to help. What would you suggest, you know, for folks who may not have a formal role in the system, but want to help, that they could do?
Marcy, I'll let you answer that just because I know you, Marcy, like I want to thank her. She's been lead on this report, but also we have, without me refreshing, there's so much people can do to help in our report, and I'll let Marcy speak to a few of those things.
Thanks. Well, I guess one of the first things that comes to mind is, and this isn't reflected in a formal recommendation, but certainly in the report there is a section around or describing what youth told us to be sort of a lack of or not enough community supports. So things like youth mentors, things like groups that youth can join and be able to talk about the issues that they're facing, sort of in collection with other young people, and just that kind of community support. I know we went to some communities that had really good systems set up for young people, and then other communities where youth just felt like there was nothing for them. So I guess that's something that I could suggest is you know, anyone has the option of talking to the youth in their community, talking to them to see what it is that they need, asking them what they need, and then trying to move forward with them on that. So I know, just thinking back to the report we did on youth suicide in Northern Saskatchewan, youth talked to us a lot about the importance of just having things to do and people to talk to and supports in that regard. So I'm not sure if that answers the question, but certainly I think that that's one option.
Great. Thanks so much for that suggestion. And I think, I think it just reinforces what you talked about earlier. It's a spectrum of supports that people need or that young people need, and it's not always necessarily just a formal service, but could be, just support and connection from others in their community, which is a finding supported by what was found in the mental health action report that was released earlier by the Saskatchewan Alliance for Youth and Community Wellbeing. Just that importance of support and connection, and that's something we can all contribute to in our communities. So thank you for that
Thanks. I was
suggestion.
just going to add one quick thing to that as the young people, if they were to help, like navigating services was tough, and we like for a lot of young people, and just even knowing where to go. And one young person said, and I've never forgot this, but it sure resonates, and I will say it's. She said, "Look, see past our smile and look into our eyes," and that can do. Anybody can do that, and see sort of like, don't take it at face value that we're okay. If you have an inkling that we're not, then like point us in the direction. Whether we go there or not in the moment might not matter at that moment, but we may go there. We don't know where to go. So that, those are the small things you can do. And when you're in your smaller communities or anywhere, that you can just take that 5 minutes to talk to that young person, and you may find out, oh, hey, they need some help. Here's where you can go. So that's to your point, Tracy.
Yeah, great. Thanks so much. Yeah, there's something that we can all do there. Another comment, just I think is more of a comment than a question, but just to see, or that the comments from the psychiatrists and pediatricians really resonated with some folks listening with their experience working in this example as a rural RN. There are probably other supports that are needed beyond that just aren't there, and especially for rural youth and families, it's especially challenging. And then another question, just wondering if there are plans to make use of resources that are available in Saskatchewan but not currently being used in this area. And I'm not sure specifically what resources are being referred to, but I guess maybe a question about, are there things out there already that we can build on that you're aware of that, can make use of things or resources or programs or services that we already have here in Saskatchewan? If there's anything you can comment on there.
I guess one thing I would say to that is so you would have seen from one of the first research question that we asked all participants was, what is working well? And so you'll see examples of those things peppered throughout the report. And I guess the first thing that comes to mind is, like I said, and as Lisa mentioned as well, in some communities there are things that are working very well. Some of these are pocketed. One example is young people told us that they really wish that there was a Alcoholics Anonymous or Narcotics Anonymous groups specific for young people. So we did hear that there are these. In some areas, they can access the adult groups, which they did find helpful, but they told us that oftentimes they would feel intimidated or, really wish that they could be there with other young people. And so that was something that, is present in some parts of the province that young people can access, but it isn't present in all areas, and that communities could take the lead from those things and hopefully even, make them a little bit more relevant to young people.
Great, thanks so much. And I think the person has clarified they also are referring to the idea of human resources and people, and specifically newcomers to the province who may have skills in this area. So, might be an offer to those listening and to others who are working in this area to take advantage of the resources we have available to us and the knowledge and skills that newcomers bring to our province as well. Unfortunately, we can't get to everything here because we only have a couple of minutes left. But I did want to just make a connection as well to something you talked a lot about, and that was, the idea of a middle tier of care, an intermediate tier of care that may not be within the formal health system. But to me, that's both a call to action and an opportunity for various sectors, health, social services, education, to kind of work together to provide those kind of integrated supports that youth and young and children need. And I think there's a lot, as you mentioned, a lot starting to happen in that area, a lot of good ideas about what could happen. And I just wanted to connect a dot with a piece of work that Health Quality Council Council is involved in. So I'd mentioned the Saskatchewan Alliance for Youth and Community Wellbeing a little earlier. After the release of the Mental Health Action Report earlier this year, coming out of a desire for people to kind of connect, to learn what others are doing, to share, to network, which I think you talked about as well, started what's called the Youth Mental Health Sharing and Learning Community. And that's a place where people can network, can connect with each other, can hear about work that others are doing, and learn together. And so I wanted to offer that to those listening, that that's an opportunity to engage in that shared learning, and we'd be happy to have you join as a member if you haven't already. So I can put that link in the chat, but just wanted to connect that dot. I think that's a good opportunity to start to spark some of this action and this innovation. With that, I'll have to move on to close off the session. I know we've just gotten going with lots of good discussion, but thank you so much for your generous offer of connecting with folks as well outside of the session. The information to contact the Advocate's Office is up on the screen right now. And I really do want to share my sincere thank you to Lisa and to Marcy for taking time to join us today and sharing this very important information with us. I know all of us on the call are looking at both, you know, what the report has identified as gaps that we need to fill, but also it gives us a lot of really great ideas about how to move forward and how to improve services for children and youth. And so as a very small token of our appreciation, you will be receiving a pair of these I Heart QI socks. So you're now part of this sock community. And also, so watch your mailboxes for those. And also, for those of you listening, if you'd like to get your hands on a pair of these socks, we'd love to hear your pitch to become a QI Power Hour speaker. We'd love to hear from you as well. So please, if you're listening and would like to share some ideas with us, we'd be happy to have that as well. Just let us know.
Great.
When
Thank you so
you
much,
Oh,
Tracy.
absolutely. Yes, thank you so much for joining us. And just one final note, when you leave the webinar, you will get redirected to a survey. Please don't be shy to click the link. It's not spam, it's not a virus. It's just taking you to the survey provider to fill out. And we'd really like to hear your ideas and suggestions for improvement of the session. We also will have an October session, which hasn't been quite finalized yet, but please do check back to the website to find out who our speaker will be and when that will happen. And we'll be sure to send out the newsletter with that as well. And so with that, I will close off our session today. Thank you so much for joining us and take care. Bye, everybody.
Thanks so much, everyone. Take good care.